maybe they will have a loss of consciousness followed by consciousness like lucid intervals. Hopefully it only occurs like in 20 to 30% depending on the where it had occurred. Yeah, patient may present with ipsilateral hemiplegia. This is the specialty of this type of hemorrhage. Yeah, and you'll know via the CT scan very easily. Yeah, we are discussing now bimodal distribution. So the old age there will be an accidental fall history or something like that. Yeah, or in the young group, that is the second to third decade. This is like the prime peak adrenaline rush going on. They are fighting, they are like quarreling here and there. We are just talking the facts here. They will indulge in like road traffic accident, that the criminal activities, all that leading to a traumatic injury. So yeah, this is the most exposed group here. The traumatic injuries are, or all of them have a bimodal distribution. Okay, got it? Yeah, now let's see. Yeah, so around 2% of all head injuries presenting to the emergency department are extradural hematoma with associated significant morbidity and mortality. So basic, so understandable. Especially with advancing age, the incidence of EDH is higher in men, with most common group affected is second to third decade, likely associated with the high-risk behavior including crime activities and participate in contact sports like rugby and stuff like that. Now just see the pathophysiology. Let's see the pathophysiology. So the extradural hematomas typically occur due to a blunt force over the head, okay, resulting in a linear fracture. These occur with no or minimal displacement. So the most common fracture is at the parieto-temporal fractures at the Terrian region. Okay, so now if we see the skull here, so this all region, this yellow region is the temporal bone, this reddish region is the sphenoidal bone, this greenish part is the parietal bone, and the blue part is the frontal bone. This area, in this area is like Terrian. Okay, and this is the most exposed part, and the middle meningeal artery is the most common artery to bleed, like in 85% of the cases. And yeah, this is the most common source of bleeding occurring due to the fracture at Terrian, lacerating the anterior branch vessels of whatever else it runs beneath it. Okay, these diploic vein blades and vascular malformation or infective pathology are less common causes of ADH, followed by this. This accounts for like 15%. The rest 15% are due to this. Okay, so we are just remembering the more common thing, that is the middle meningeal artery. This. Okay, this. Yeah. So we have ventured about this. So let's see the clinical features here. Yeah, so sorry. Yeah, the clinical features. So the extradural hematoma mostly present following a history of trauma or fall, as we have discussed. Okay, and there is an initial loss of consciousness followed by a lucid period and further deterioration. Okay, but I believe this in present only in 20 to 30% cases, as I have mentioned earlier, and it may include headache, nausea, vomiting, and progressive drowsiness. GCS may fall rapidly, and this is the criteria for choosing the management respectively, as we will discuss further. So these patients may have a low conscious state, okay, localized neurological signs, and the clinical features of brain herniation or raised ICP, and this can also progress to coma and further death. This mortality of this type of patients are like almost 30%. So yeah, let's see this picture very closely. So this blue lining, as we can see now, this, or just let me this lining is the dura mater. Okay, above, outside this is extradural, and beneath this is subdural. Okay, this area is like the intraparenchymal, and this is like subarachnoid hemorrhage. Okay, now let's see the coronal view. Yeah, getting it. Yeah, this is the dura. Outside is extradural, inside is epidural. Sorry, extradural and epidural is same thing. Inside is subdural. This is parenchymal, this is arachnoidal. Okay, subarachnoidal. Okay, yeah, now let's go through the investigations. So here we can see this or this. Okay, this area, this is the biconvex area, hyperdense biconvex lesions. This is the CT scan, this is the MRI view. Okay, now all patients presenting with suspected traumatic should be investigated and managed as per the ATLS, Advanced Training Life Support. Okay, for initial investigation, routine urgent bloods, FBC, CRP, clotting profile and group and saves should be taken. Okay, now the CT imaging of the head should be done. So the ADH will show the hyperdense biconvex lesions potentially associated with a skull fracture, as we have discussed. Further imaging may be required thereafter for follow-ups. Okay, yeah, fine. So we are like, okay, yeah, this is the typical presentation. This the biconvex area. Okay, yeah. Now the management part, the very important part. Okay, all the parts are important, but yeah, this management is severely important. Yeah, so as discussed, majority of ADS is traumatic in nature, therefore should be managed according to ATLS. Okay, now the urgent neurosurgical opinions should be taken, and based on this current management guidelines from Brain Trauma Foundation, that not all EDH require surgeries, only more than 30 centimeter Q should be managed surgically regardless of other factors, and less than 30 centimeter Q with low thickness and a minimal midline shift and a fifth GCS of more than 8 without any focal neurological deficits can be the candidates for conservative management. These lines are very, very important, and for the management we should always consider this current management guidelines from Brain Trauma Foundation. Very, very important point, can't miss. Yeah, let's see the conservative management. Okay, yeah, so the conservative management typically involves serial of CT imaging, just to follow up and for close neurological observation. While no specific surgical procedure shows definite benefit, but craniotomy may be preferred in certain circumstances over the burr holes. So any bleeding source identified are localized and be controlled through ligation or cauterization if necessary. And post-operatively, patients should be observed on either a neurocritical care or a high dependency unit or a neuro-observational and routine post-operative CT scans to ensure adequate clot. And there should be neuro rehabilitation whenever required. So the prognosis, so overall mortality rate is 30%. The poor prognosis includes increasing advancing age, temporal location, low GCS. Like the severe GCS is like less than 8, that is 3 to 8 is the severe category of this, and the incidence of herniation or raised intracranial pressure. So now the last key points are extradural hematomas are typically traumatic and arterial, as we have seen, occurring most commonly in younger men. As we have seen, classical presentation is of lucid interval, then rapid progression to signs of raised ICP and herniation without intervention. Okay, CT imaging will show in hyperdense city, there is a biconvex presentation and does not cross suture line. Okay, we have seen this also. And the management is extradural hematomas can be managed conservatively or surgically depending on a number of factors we have discussed, including size, midline shift and GCS. So guys, very, very thank you for listening. Okay, have a great day.